Hello, this is Mike Nicolai, the school's Chief Human Resources Officer, and I'm here with Dr. Terry Redman. And Dr. Redman, we're receiving some questions in our community about some recent press reports about COVID being transmitted through aerosols. We're hoping you could answer some of those studies that have, and press reports that have come out recently.
Sure. So in the webinar that I gave earlier to your school, I talked about respiratory droplets versus airborne spread diseases. And in healthcare epidemiology, that's because we divide disease transmission into those two routes, what we call droplet versus airborne spread diseases. But that assumes that a disease that's spread by respiratory droplets means that all of the infectious particles fall to the ground within 3 to 6 feet of the source. And then for airborne spread diseases, that the infectious particles travel longer distances on air currents and stay in the air for long periods of time. In reality, there's not a clear dichotomy between those two categories. It's more of a continuum. So we generally talk about infectious respiratory particles as being either large, what healthcare epidemiologists call droplets, the respiratory droplets, or they're small, and some people call these aerosols, but healthcare epidemiologists call those airborne droplet nuclei. In reality, there's actually a third category in between there that we don't officially have a name for it, but we all know that it exists, and we kind of think of it as a small particle aerosol. So we know that these come out of the nose and mouth of people who have some respiratory spread diseases. So if you're near somebody who has this disease, a number of these medium and smaller size particles do come out of their nose and mouth, but there's likely not enough of those to meaningfully contribute to infection. And if they were expelling enough of those aerosols to actually cause disease, then we would see that in epi studies, which we're not doing. And this is especially true when everybody's wearing a mask, because the tiny number of small particles that are coming out that might even travel a little bit farther, might go 10, 12, 15 feet, does not appear to be enough to actually cause an infection. We're just not seeing that from an epidemiological standpoint. So if in a situation in which you're exposed to multiple people, especially in a large gathering where multiple people are expelling some of these small infectious particles, and if people are not wearing a mask, then the number of those small particles can increase in that area, and that could potentially, this is all theoretical, could potentially play a role in outbreaks in addition to droplet transmission. This is completely theoretical. So again, we don't have a single epidemiological study that has demonstrated that these small infectious particles actually play a role in COVID-19 transmission. So the studies that have been done have all measured viral RNA in the infected person, in the air, and on surfaces, and in body fluids as well, like feces. But the presence of the viral RNA does not equal risk of transmission. We just don't have enough evidence, in other words, that it's actually spread by these aerosols, but theoretically, it could be possible. And it would not be that surprising if some of those small particles did play a small role in disease transmission, because other respiratory diseases can be spread by aerosols. So we've seen that with other types of diseases. But where it's really important here to sort of differentiate is there's a difference between aerosol transmission and airborne transmission, like TB or measles, related to those small particle aerosols. Airborne spread diseases have really high basic reproduction rates. There's like a ton of secondary disease transmission, up to like 10 people or more, and household transmission rates that vary between 50 and 90%. We are not seeing that with COVID-19. The basic reproductive rate of the R naught is close to 2 to 3, and it's just not acting like an airborne spread disease. We just have a ton of data that says that this is not airborne. Now, we might eventually have studies that actually find that SARS-CoV-2 can be spread by these small particle aerosols, But that doesn't mean that our actions are actually going to change. So I think that some people are under the impression that if we all just admit that aerosols are involved, that suddenly that means society is going to do something completely different. We're all going to wear N95s. We're going to put everybody in negative pressure. That isn't true. This is not, that only happens with airborne spread diseases. And again, this is not an airborne spread disease. So we have many, many epidemiological studies that show mask use, distance, and hand hygiene are working. They protect against COVID-19 disease transmission. So we are not suddenly going to change, even if we say aerosols play a role in disease transmission, which we can't definitively say yet, but could happen in the future. We're still not going to change the actions that we're choosing as interventions. We're not going to switch to respirators. We're not going to say you suddenly have to have 12 feet between people. This is not an airborne spread disease. Again, even if we discover that aerosols might play a small role in disease transmission. So sorry that answer was very long and kind of sciencey, but I hope that it's a gray area, right? Like it's not that dichotomy that I originally, the way we usually talk about it in terms of healthcare epidemiology.
Thank you very much. If I could ask a couple of follow-up questions. So there's been concern that based on these reports that people will be at greater risk if they're taking an elevator, even if the elevator has capacity limits like we're talking about. And also, and related, passing someone in a hallway or passing someone in a stairwell, that because it may be transmitted through aerosols, that this could change the exposure to people.
It's not going to change that risk of infection transmission. So it still comes down to time, distance, and masks. I mean, ultimately, that's what we're looking at. So you still have to have that prolonged exposure, close contact, not wearing masks in particular, that really lead to disease transmission or prevention of disease transmission.
And then would the same apply to public transportation? Because given our setting, we have the vast majority of our community will take public transportation to get to our campus.
Yes, I haven't heard a single healthcare or infectious disease epidemiologist talk about how we would need to stop using public transportation or using some other kind of intervention in public transportation to stop disease transmission. It's obviously, it does pose a higher risk because you're in closer contact for potentially a prolonged period of time. But if everybody's wearing masks and trying to stay as far apart as possible, as much as possible, that's going to minimize disease transmission risk.
And another follow-up, this is your professional opinion, but do other of your colleagues or professional societies share this same opinion?
They do. So I'm a member of the APIC COVID-19 task force, and we communicate regularly with the CDC. And I also communicate regularly with public health officials, not only in St. Louis, but maybe not all parts of the United States, but many different areas. And individuals who really understand disease transmission, healthcare epidemiologists, infectious disease epidemiologists, we all share the same opinion about how this disease is spread, what we currently know about how this disease is spread, and what we know is actually working to stop disease spread, which is distance, time, masks, and hygiene.
Thank you very much, Dr. Redman.